we are on time, so I'm gonna open the conference. We begin.
Hola, buenos días a todos. Muchas gracias por acompañarnos el día de hoy a nuestra sesión académica. Bueno, de parte de la Agrupación Mexicana de Oncohematología Pediátrica, tenemos el honor de que nos acompañe el doctor Milen Minkov. Bueno, él es director de pediatría de Vienna North Hospital. Fue presidente del hospital de la Sociedad del Histiocito de 2016 a 2020 y actualmente es jefe del Centro Internacional de Referencia de Histiocitosis de Células de Langerhans de Santana Children's Cancer Institute. Hello, Dr. Milen, how are you?
Hi, hola. So I'm very happy about this invitation and the possibility to speak to your colleagues.
Thank you very much. On behalf of our society, yes, we can hear you perfectly clear. So on behalf of our society, we really appreciate that you can give us this lecture today. So shall we begin?
Hello.
Hi.
Hi, thank you very much, Doctor. I am Marta Zapata. Nice to meet you.
Nice to meet you too. Should we start? Should we start with the lecture?
Yes, please.
Okay.
Yes.
So, thank you for this invitation and hello to everybody who is attending our session. Today I'm going to talk about the Langerhans cell histocytosis in childhood and to give you a clinical overview, and I try to prepare a mixture, some more pictures and images about the clinical manifestations for the younger colleagues and a little bit more about the treatment and the new findings for the more experienced and more advanced of you. And of course, you're welcome to ask questions anytime when you have some questions. So this here is an outline. I'll give you just a short historical perspective to understand how this concept of LCH has evolved over the time, a little bit about the pathobiology, but then try to spend most of the time on the clinical manifestations, standard of care, the challenges you'll meet with your patients, and yeah, this is more or less what I'm going to talk about today. So I would like just to say that the data I'm showing you and the knowledge we have is actually due to the excellent cooperation of many countries of both sides of the ocean under the umbrella of the Histiocitosis Society and this international organization. And now at the moment we have two subgroups. One is the NACHO from the North American Consortium for Histocytosis, and we have just founded a European one, the ECO. And then we are very thankful for the Histocytosis Association. This is a parent organization from the United States who support our activities and manage our congresses. There is another more or less private initiative in Greece, the Nicholas Symposium, where every year about 10 to 15 specialists from different areas of the pediatric oncology or from adult oncology come to share some ideas from myelodysplastic syndromes, from other diseases, to try to implement some knowledge into the histiocytic disorders and to make advances. And the Santana Children's Hospital, as you know, is the international reference center for histocytosis since almost 35 years. The LCH has a very long history, and these slides shows you how heterogeneous this disease is. And originally, the physicians have described this as 3 different diseases, starting with the one less severe and mostly chronic form, the so-called Hand-Schuller-Christian syndrome, which included at that time a typical characteristic of exophthalmos or proptosis, the bone, skull bone lesions, and diabetes insipidus. Later, the eosinophilic granuloma, the isolated form of the disease, has been described, and in the about the 1920s, 30s, the most severe form, the later receiver disease, has been described. And it took some decades until the pathologists realized that if you don't tell them what the patient has, looking at the microscope, they cannot say you which disease they see. So, and there were two pathologists from the United States, and particularly Liechtenstein, who realized that those three diseases actually under the microscope look very similarly. And he said, this is one disease, and called it histiocitosis because he saw their histiocytes into the lesions, and they gave the sign X because it was unknown what is the cause of disease. Is it a malignant one? Is it a reactive one? Is it an infection? And this histiocitosis 6 as a name existed in the literature till nowadays, but about the 80s, another pathologist from France, pediatric pathologist, Professor Nezelov, studied these histiocytes in LCH and found that they have a phenotype which is very similar to the Langerhans cells of the skin and the mucous membranes. That you know that Langerhans cells and normal Langerhans cells are dendritic cells, they are antigen presenting cells. And he particularly found under the electron microscope that the cells in LCH have Birbeck granules in the cytoplasm, and this has been thought to be really a hallmark of the normal Langerhans cells at that time. And this changed the name of the disease to LCH. And except for changing the names, there's been not a lot of knowledge to understand the disease for many, many years, almost 400 years. And it was just recently, 10 years ago, a group from Boston, the group of Barrett Rollins, found, or more or less by chance, they put their archive material on a very big platform when they studied cancer in adults. And those platforms are very powerful. They look for many, many hundreds of genes, and they by chance found that patients with LCH, with about 2/3 of the samples they had, have positive BRAF mutation. And this was the first discovery that this clonal disease has a genetic background. And since then, we made a lot of other discoveries. Now I understand this is a little bit more. And in those slides, I also like to show you that prospective clinical trials in the field of pediatric oncology started in the early 1960s, but with few institutions in the States or in Europe, it was impossible to have really good relevant findings. And it was not until 1991 that the Histiocyte Society started international trials, and those trials gave us important observations. And on those trials, the result of those trials, we have nowadays the standard of care for this disease. Shortly about the pathobiology, as already told you, 10 years ago, this was the original publication in Blood. The group in Boston found that 2/3 of the samples have these BRAF mutations, V600E. And this mutation is actually not specific for LCH. You may know that in the adult oncology, it is positive in many different types of cancer, in melanoma, in thyroid cancer, also in colon carcinoma, but even in pediatric tumors, in the brain, some of the brain tumors are also positive for these mutations. So you can firstly conclude that the mutation is not a private mutation of this disease. The second most important observation of this first publication is they had no explanation, but they mentioned that actually 2/3 of the patients have the mutation, but all patients have actually phosphorylated ERK. And this is the most downstream part of the pathway. And that allowed us to suppose that in the MAP kinase pathway should be another mutations which activate this. And nowadays, of course, 10 years later, we know there are now maybe 2 or 3 different bigger cohorts. They all established that about 50 to 60% of the patients have this BRAF mutation. And from the patients who are BRAF negative, about 1/2 have MEK mutations. This one, MEP2K1 mutation. And then there are other rare cases who have BRAF deletions or some fusions and so on. And there in LCH still about 25, about 15 to 20% with still not identified mutations. And the common for all these mutations, they affect the same pathway, the one which is very well known to you, because in oncology, it is the most commonly evolved pathways, the RAS, RAF, MEK, ERK, a transduction pathway, and here you see the most common mutations. And then it started to be clear that we deal with a really neoplastic disease. The questions came, should we call it cancer or not? But it still was unclear how those mutations cause LCH and why in some adult patients they call hairy cell leukemia, and the same mutation in pediatric patients can cause histocytosis. And there has been a couple of years ago another publication who showed us that it is not a classical cancer. It's not like in carcinoma or in leukemia that you have an overproliferation of cells, but it is rather accumulation of cells which stuck into the skin on other organs. You know that usually the normal dendritic cells, if they come into the skin and come into contact with antigens, then have they are driven by the CCR7, the chemokine receptor 7, and they go to the lymph nodes to perform the presentation of the antigen to the lymphocytes. And those disordered cells with the mutation, they actually stuck and they do not drive further, and they accumulate in the skin, and the same way they can accumulate on other organs. And the second observation in this study is that they also have increased expression of BCL2 like protein 1, and it is known that it reduces the apoptosis. Therefore, you have actually cells who stuck into the tissues and who are not dying as they have been programmed to do it. And therefore, you have actually accumulation. This is what the pathologists usually see. They don't see a lot of proliferation. It is more or less accumulation of cells who stay in the tissues. And recently, our group published a very complex paper based on epigenomics, on a lot of sequencing and so on. It is complex. You can read it. I can just say that we have from this paper have knowledge that the differentiation and maturation of the cells, the mutations have some abnormal pathways. They don't do the usual pathway just to give you the normal antigen presenting cells, but there are a lot of subpopulations which have destructive character, which can produce cytokines causing inflammation and so on and so on. I think that this paper gives much more questions than answers, but it makes clear that maybe the microenvironment and some epigenetic factors play a role in this disease, and the disease is not that homogeneous as we thought, but it is like in leukemia, you have a lot of different clones of cells at different types of maturation. So to summarize it for the clinicians and not to do it very complex, nowadays we know that we have precursors of the hematopoiesis, precursors of the monocytes of the dendritic cells, which acquire the mutation in some stage of their development, and then they have those inflammatory properties. They stuck into the involved tissues, and they have reduced apoptosis. And when these infiltrations happen in the tissue, they acquire other inflammatory cells, and you usually see also eosinophils on plasmatic cells and lymphocytes into the lesions, and those cells start to talk to each other. They produce inflammatory cytokines and TNF, and in some patients, it is a local process, but at some point, this process could be generalized, and depending on this, you have a localized or a systemic disease with destruction of tissue damage, like osteolysis of the bone, fever, cytopenia, and so on. So this is the understanding, but of course, the very detailed mechanisms are still to be dissected. This concept, and I think that you asked me the questions, but okay, if you have one mutation, and it is in the lineage of the monocytes of the dendritic cell lineage why we have such a different disease, which has been described as 3 different entities in the past. I think like the concept in lymphomas, it is not important the mutation itself, but it is important at what stage of differentiation this mutation is acquired. This means if the mutation is acquired in a very early precursors in the bone marrow or very close to the stem cells, you will have a very advanced high-risk multisystem disease. If a more committed precursors acquires this mutation, then we'll have more limited disease, maybe multifocal bone on board with something more the skin or diabetes insipidus. And if the mutation is acquired by the very mature cells which are already in specific tissues, then you will expect to have a single system disease, for example, single system, single site bone lesions. And of course, there are some data that maybe cells not coming from the bone marrow, but even early into the development, during the embryonic development, the yolk sac cells, if such mutations happen, they can result in the self-healing congenital this is a special form of LCH, self-healing congenital skin LCH, which is usually spontaneously regressing. But this is also a hint that maybe the neurodegeneration in LCH, which is not very well understood, why should a bone marrow disease cause neurodegeneration? There are some data on mouse models from the States that cells precursors of the erythroids and the megakaryopoiesis, which originate in the yolk sac, they populate the brain, and they actually normally populate the brain and form our microglia. And if the mutation happens before this population normally proceeds during the embryonic development, then you will have a microglia with mutation, and this would lead into neurodegeneration and bone and then brain destruction. So these data have been produced on mouse. It is still disputable how it is about people. There are 2 hypotheses in the moment, that the brain is developed maybe in a yolk sac mutation, or that cells coming from the bone marrow, inflammatory monocytes and histiocytes come through the blood, like in other disease, like a metastasis, and then they cause the brain damage. Now, enough about the biology. Now we're talking about the clinical manifestations. This disease can happen in any age group, from newborn till very old people in 70 and 80 years, but it is mostly described in children. The incidence is about 4 to 5, 6, 7 children per 1 million children a year. This means it's 1/10 of the frequency of the pediatric leukemia, and its male to female ratio is about 1.2 to 1. It's a slight male predominance. And there are 3 to 4 clinical forms. For example, there is one very peculiar form, the white one here. This is isolated involvement of the skin only. It could be nodular lesions, it could be a rash, but it is typically seen in infants and newborns and infants before the first year of life, or during the first year of life. Then the multisystem disease involving more organs is also happens predominantly during the first 2 to 3 years of life. And you see that the skeletal disease, unifocal or multifocal, could be seen in all pediatric age groups. And here you see the frequency of the organ involvement. You have to keep in mind that per definition, there is a single system disease, and the single system disease is in the majority of cases a skeletal disease. Therefore, bone is involved in both single system and multisystem disease. Therefore, it is the most commonly affected organ. Skin is the secondly affected organ. It could be also isolated skin disease or skin in a multisystem disease, but it is not so frequently seen in a single system disease. Therefore, most of the skin involvement is in the setting of the multisystem disease, and the same is true for liver, for spleen, and also for hematopoietic dysfunction. And lung can be, in children, is almost exclusively seen in the setting of multisystem disease, but in adults and in adolescents, it could be seen as an isolated lung LCH. Here some examples how those lesions look like. Here are bone lesions in the flat bones. Very typically, almost the most common localization is the skull bones, and it is the calvaria lesions. Then you can, of course, have the flat bones of the vertebral column. Here you see in a compression of the vertebral compression. Then, of course, also scapula. It is a rare localization, but can also involve looking like a soft tissue tumor, but also with destruction of the bone. Then, of course, also pelvic bones can be affected, and here you have a differential diagnosis with Ewing tumor or with other diseases. And in this child, it was not only the pelvis, but also one of the femur has been involved. And here's just an example, a femoral lesion in the femoral neck, and you can see that the different techniques give you different advantages to see the lesions. Nevertheless, usually in the international protocols, we require a skeletal survey in order to make such studies possible in all countries. But of course, CT or MRI have some advantages. I'm not going to spend time on this later, but just would like to warn you that MRI is an excellent technique, but it shows too much. It shows involvement in the bone marrow like in other diseases. So therefore, in MRI, you can see lesions which are not visible on X-ray. And sometimes it is for me questionable whether these lesions seen on MRI only have really impact on the disease outcome. And in MRI, you can see lesions in the bones of the hands and of the feet. And usually we know 20 years ago that those locations usually are spared by the histocytosis. And I see some such lesions from colleagues who send me images. And actually, if you wait to do nothing, those bone marrow signal lesions can disappear over the time, because they can be due just if the patients have done a lot of exercises or due to the treatment you give. So I warn you to be cautious, and usually I try, at least for the long bones, which are very well visible on the X-ray, to verify such lesions on X-ray. And if they're not visible and asymptomatic, I sometimes tend to neglect some of those lesions. Then one of the very first manifestation, part of the Henschel-Christian syndrome, was the exophthalmos, or in English, proptosis. It could be unilateral or bilateral. Usually is due to involvement of the orbiter-forming bones. But sometimes, if you have a temporal bone involvement, you can have also swelling, a soft tissue swelling, which is outside of the orbiter. Then the skin involvement could be quite typical. Nevertheless, it is not diagnostic. In some cases, it could be very characteristic, like in this child here, and be very extensive rash with something looking like petechial rash and like hemorrhagic rash. But in some patients, it could be like a seborrheic dermatitis. So without biopsy, you can't diagnose it. And this is here also like a seborrheic one. And there are some newborns and very young kids who have this chicken pox like lesions, which also can be misdiagnosed with some congenital infections. So you have to be careful, and usually you need a biopsy. Here are some differential diagnosis. This here is a very rare lesions of so-called congenital self-healing reticulohistocytosis. Usually you see it at the newborns and during the first some weeks of life, and they disappear themselves. This child had 2 lesions. The one was almost healed, and this is the ones I could catch and then make a picture for you. And then there are some other histiocytic lesions, but these are non-LCH diseases, like a juvenile xanthogranuloma. Here you see typical xanthogranulomas. Here the microxanthogranulomas, had other types, they can be also different, but if you have seen a couple of them, you recognize them. Nevertheless, you need a biopsy to confirm the diagnosis. Here also nail involvement in histocytosis, and here you see two things. The skin has also skin lesions, but also you see the involvement of the oral mucosa and also involvement of the jaw with teeth loss. Here is just mucosal hyperplasia and involvement in this child, and there are also cases with involvement of the genital mucosa, and it is not very well known. This young lady here suffered for almost 2 months until the doctors realized that this could be histocytosis on biopsy. There's ulcerating, very painful lesions. And this was a small child with polypoid-like lesion here, which this perianal, which disappeared on treatment. And this is one of the very, very few cases of involvement of the penis. This was a patient who had leukemia before the histocytosis and then developed histocytosis, and the cells actually showed the same clonal mutation. And the patient unfortunately later developed histiocytic sarcoma and died. And here is an example of the severe multisystem diseases, extreme hepatosplenomegaly, as you can see also on the MRI images, and very severe skin rash in a child with fever and pancytopenia and so on. Here, involvement of the lungs, you can see the bullae, also bite sites on the X-ray, you can see them on the CT. Those patients can have problems with recurrent pneumothoraces and be very challenging and need time with chest tubes and spend up to months on intensive care unit. But if you manage those complications, they can recover very well, and 10 years later, you can see that they have completely normal lungs. So such patients have to be treated. Don't give them up. This is something different. This is involvement of the brain. The first image shows a very typical involvement of the hypothalamic pituitary region, which usually involves the pituitary stalk or the hypothalamus and causes diabetes insipidus. And this is a complication seen up to 25–30% of the patients with multisystem disease. This is a rare other complication. It is a granulomatous LCH of the brain. It looks like meningioma. So for the diagnosis, of course, you need a biopsy. And the same picture can be seen with the non-LCH, like Erdheim-Chester disease, with Rosai-Dorfman disease, juvenile xanthogranuloma. They all can make such productive type of lesions, mimicking tumors, or involving also the ventricles and the choroid plexus. And here you see another type of neurological involvement. It is usually a complication of disease coming years after disease elsewhere has been cured. It is so called non-granulomatous LCH, or the neurodegeneration type LCH. Usually involves both the white matter and the gray matter of the cerebellum, and also involves can also involve the basal ganglia. Questions till now, or should I proceed? I think we can do the questions at the end. Now about the standard of care. Diagnosis, as already mentioned, needs a biopsy, and you don't need the electron microscopy. It is still written in some books, but it is obsolete because nowadays we have a very good markers on the immunohistochemistry, particularly the CD207 stands for Langering, and actually this is the content of the Birbeck granules. So if you have tumor with appropriate pathology and which is positive for CD1A and CD207, you have convert diagnosis. You can, in addition, use S100, but this is actually enough. Once you have established the diagnosis on pathology, then as you are used in oncology, you have to do staging, you have to define the dissemination of disease. In the histocytosis, it needs few tests. You need very exact clinical examination and looking for the typical presentation as already shown on the pictures. Then you need CBCs and the liver test, particularly to see in liver there are two different patterns. One is pattern is with hypoproteinemia and maybe increased transaminases, but there are some patients usually developing sclerosing cholangitis, which is really very, very severe complication, and such patients could not be treated with the chemotherapy. They usually need liver transplantations. Fortunately, they are very rare in our experience, but your colleagues from Argentina have shown that there is some predilection for the Latin countries, and for some reasons they have much more sclerosing cholangitis. There is a publication from Garahan Hospital, and we don't understand why. In Europe, we don't see that often. And then the imaging is quite a controversial area. We can spend 1 hour just discussing why still using X-ray. I already told you, of course, MRI and CT are excellent technique with very high sensitivity. However, we are still lacking prospective studies to know what is the clinical impact of the lesions. Because in the same patients doing X-ray and finding one lesions, you will wait and watch and do the biopsy only. But if you do MRI and find another 2 lesions, according to our guidelines, you have to treat the patients because it's multifocal ball disease. But we know from the old German studies that patients who on X-rays have only 1 visible lesions do very well with local treatment alone. And this is the reason why we still prefer the skeletal survey. But I have to confess, of course, you have some lesions and the vertebral lesions or on the skull base. Of course, you need MRI and CT because on those locations, X-ray is not sensitive enough. And in those locations, you're also interested to see the soft tissue component of the lesion. But if you'd like to see the guidelines from our European group, it is the reference here, and you can see what we're recommending and why we're recommending. Based on this staging or this initial evaluation, you know the extent of the disease, and then there's a simple classification into single system, LCH, and multi-system disease. Multi-system means involvement of at least 2 or more different organ systems. Single system disease can be single site or multiple sites, and this is predominantly bone. There are rare cases of isolated skin disease, extremely rare cases on lymph node disease only, and then there are some patients with isolated disease in the CNS, in the lungs, the thyroid, but they are exceptional cases. And patients with multi-system disease, we have also the so-called defined risk organ involvement. This means involvement of the liver, spleen, or hematopoiesis. The standard of care for single system disease is based on experience of old studies from Germany, and this paper has been published at MPO. This is the preceding Journal of the Pediatric Blood and Cancer 2001, and you can see that among 170 patients with single system musculoskeletal disease, the survival was 100%, event-free survival almost more than 80%, and only few reactivations, most of them, once again, localized to skeleton, to bone. Therefore, those patients will not die. You can also treat them conservatively, and look, if there's a reactivation, you can retreat them. There are some arguments to treat them aggressively because those patients have permanent consequences, sequelae. But if you take into account that 50% of those sequelae have been there at the beginning of disease, let us say diabetes insipidus as presenting symptom, you can't prevent those sequelae. Therefore, we recommend nowadays for patients with single system disease, it is a skeletal disease. You have to differentiate. If it's unifocal, you need at least a curettage or biopsy, and this usually is enough for the lesion to heal. If it's a multifocal disease, we recommend systemic treatment. There are few patients with skin disease only. Most textbooks say give local ointments with steroids and so on. I don't think that it's correct, because if the patient comes to pediatric hematologist oncologist, the patients has already been treated by a pediatrician or dermatologist with different topical creams, didn't improve. The biopsy proved that it is LCH, so usually they don't respond. And I have evaluated in the past about 60 cases of isolated skin disease and saw that among 60 patients, 4 progressed to multisystem disease and 2 out of them even died. But those were patients in the 80s. So I would suggest of patients, babies with isolated extensive skin disease to be treated. Here, to avoid questions, my experience is that skin lesions could be 2 different types. Nodular lesions, similar to juvenile xanthogranuloma, you can resect them. But if it is a rash and it is extended, I usually will treat such a child systemically. And lymph node involvement alone is very, very, very rare. Of course, it's one lymph node. You'll never suspect LCH. You'll have the diagnosis after you have big lymph node, you resected it, and then you have the diagnosis, but the lymph node is already removed. If it's multifocal, of course, you'll give a systemic treatment. The treatment of multisystem disease is based on the 3 international studies, LCH1, 2, 3, and based on the cumulative experience, we found that over the time, we succeeded to improve the prognosis of multisystem disease. And here on this slide, be cautious. Here are not all patients with multisystem disease. Here are only patients with risk organ involvement, the most severe form of the disease, the only patients who usually die on disease. And even in this selected subgroup of multisystem LCH, the survival rates is approaching 90%. And I think nowadays with some additional options, it should be almost 100%. And therefore, we decided to give a standard of care, the treatment of the schedule of the LCH3 protocol. It is very simple, inexpensive, and well tolerated. You start with steroids, 40 milligram per square meter a day, and weekly vinblastine for 6 weeks. Steroids are tapered after 4 weeks of full doses and tapered over 2 weeks. And then we make an evaluation. If a patient is very excellent response or even complete remission, then you go to continuation treatment. If a patient has responded, but there's still a lot of disease activity, still skin or something else, then you can repeat the course, but usually with intermittent steroids in order to avoid cumulative toxicity. And then after the week 12, you go to continuation treatment, and the continuation treatment is given up to total treatment durations from here to here of 1 year. And this is the standard of care. Questions here or related to at the end? Okay, if you have seen patients have experience with this, you will know that it is nice what I told you till now, and this inexpensive and well tolerable treatment can cure most of the patients. Nevertheless, in the past, we also lost some patients. And there is another problem, that there are patients who are not, as to the mortality, we have reduced it now. And I think this is not the problem anymore. But we have a lot of morbidity associated with recurrent relapses. The patient usually do not die, but they have more relapses in bone or diabetes insipidus or other problems. And those patients who have more relapses or more chronic disease course, they have a high probability to develop some sequelae. And those are the patients who have poor quality of life, even if they survive. And those are the patients who are still looking for alternatives if the first-line treatment is not sufficient, what to do. And we are now, since 2012, 2013, we have the international SH4 protocol with many strata. I don't have time to go through it, but the first-line treatment is based on the standard treatment I already told you. And now we have 22 participants in 22 countries from 4 continents. And we have also Australia, Asia, Europe, and the North America. From your continent, unfortunately, we have over the years the Argentina, but the colleagues didn't manage to to fulfill the GCP criteria. But nowadays is everything very complicated. In the past, we were not that strict, and we have also some interest from Brazil, but they also didn't manage to open the protocol. So actually, your continent is represented by Canada and United States, and maybe you can join the next one, because I hope that to do it in the next 2 to 3 years, we'll be ready on this protocol. The unmet needs of the patients or of us as physician is how to cure LCH, which with the standard treatment is not responding, is progressive. Those are the patients who early died. What to do the patients who respond, achieve remissions, but then relapse over and over again, and how to prevent the permanent consequences and improve the quality of life. And of course, our dream is not to base our stratification on counting lesions on X-ray, on MRI, but to have some biological markers which would give you the possibility to assess disease burden, then to judge the treatment response, and also to stratify and to decide when to stop. And I can summarize that the patients who have multi-system disease and with the treatment I already show you do not achieve remission, there are two problems. One are those patients who are not responding but worsening. They are awful. Those patients are even more difficult to treat than myeloid leukemia because they have fever, they have huge organs, they have transfusion dependencies, and usually die on infections, on bleedings, and so on. And in leukemia, at least if a patient fevers, you know he has infection. Here, fever is part of the disease. So you don't know to change the chemotherapy, to change the antibiotics, to give more steroids. It is very challenging patients. The non-risk disease, those are patients who usually have no severe disease or have severe disease, but they respond, they achieve remission, but then relapse and relapse again. Or patients who respond, but not completely, so you can't stop treatment. You need something in addition. So those patients usually are not going to die, so you can't use some experimental options for non-risk patients because the risk to die is zero. They have other problems. So what you can do for the non-risk patients, in the past, they have been neglected because you knew that if you repeat steroids and vinblastine, they will achieve the next remission. Of course, as oncologists, we are happy to have remissions. But if you look at such patients, they usually achieve remission whatever you give. You can repeat the first-line treatment. You can give them RSC or 2-CDA or clofarabine. On the other drugs, you can give 6-MP indomethacin. You can even give bisphosphonates to achieve remission. But you usually do not cure them until the disease does not stop itself. So they are challenging, and I think that for those patients, you need trials with different endpoints, not just survival, not just remission, but to see whether the patients can be cured, whether you can reduce morbidity and so on. And for those patients, of course, some colleagues, particularly from the States, are thinking about giving the inhibitors, BRAF or MEK inhibitors. I think that this disease does not justify the risk of those medications, but it's also debatable. More difficult was the situation in the past with the high-risk disease. And for those patients over more than 20 years, we had two options. One was the hematopoietic stem cell transplantation, and one was very intensive chemotherapy with myeloid leukemia protocols to CDRSA combination. And then, of course, for those patients, you need high level of supportive care. Otherwise, you lose the patients on the treatment. And nowadays, you have as a third option, the BRAF or the MEK inhibitors. Briefly, what about the hematopoietic stem cell transplantation? There has been one study of our group with about 9 to 10 patients, 9 patients. You see those patients are heavily pretreated, the most severe disease form. In the 80s, survival rate was 30%, worse than in leukemia. With transplantation, you can have 80% of cure in those patients. But we don't know what is the best conditioning. At that time, we knew that with all the supportive care, without defibratids and so on, with myeloid with myeloablative conditioning, we lost the patient. You see over the time, the supportive care and the transplantation has improved. And then there has been a study looking at the EBMT registry, and they didn't find any difference anymore between reduced conditioning and myeloablative conditioning. So it is very disputable nowadays. And I think that in the past, you did transplantation as a real salvage. Patients who were going to die with huge organs. So I don't have time to explain all these tricks and things, but we had to treat them even after day 0 with steroids and vinblastine until the new immune system started to cure the disease. So it was not like in leukemia. Leukemia have a remission and you transplant in remission. In LCH, at that time, there have been no possibility to bring the patient to remission. Nowadays, with the availability of the BRAF inhibitors, I'm going to talk a little bit about this, you can bring the patient, all patients into remission. Therefore, I think that maybe it is wiser nowadays to use myeloablative conditioning, because then you don't have a lot of toxicity. Patients come in remission into transplantation. They are not transfusion dependent. And with this kind of preparative regimen, you are not risking to have rejection, and particularly not to have a mixed chimerism and not to have some autoimmune phenomena. And another problem with the transplantation is also availability of donors, but the Chinese colleagues have also found some new ways how to do haploidentical transplantation. So it is also something you can consider. And this is what we still suggest in our protocol, in SH4 protocol, the non-myeloablative conditioning with fludarabine, most immunosuppressive based melphalan and Campad, but we actually can treat the patient in other ways nowadays. I don't think the transplantation plays a good role. So this is the summary briefly about that. It is the available knowledge you have is very old, and you have to define the role of the transplantation nowadays with the possibilities to bring patients into remission. So we need studies. The chemotherapy, which can be curative, has the same effectivity, but you see this is a myeloid protocol, RRC2CD, very toxic. And this is the original publication of the Histiocitosis Society, which says, yes, it is a very effective treatment, can also salvage 80% of those patients who earlier died and had survival of 30%, but you're going to lose a couple of patients with toxicity. You need very experienced hands and full supportive care. So this is the conclusion, and we are very cautious to offer this treatment, but it works. This is the summary on this regimen. And then clofarabine has been published by the colleagues from the States, and it is quite effective, but it is extremely expensive. It's difficult to afford it, and it could work even in severely ill patients, but the experience is still limited. And now, of course, you'd ask the question, what about the new drugs? Because you have now mutations, you can approach them with targeted treatment. And 2 papers has been just published last year. The first I show you the one published in Blood by the Nacho group. This was a Nacho Libre study. And they published about 21 patients. They have kind of mixture of patients who have not only active disease, but also neurodegeneration. Some patients have no neurodegeneration, and neurodegeneration is difficult to judge because you do not expect a lot of improvement if the patients have damage. Nevertheless, they treated the patients maybe in about 1 year and so on, have very good response rates. And the response in CNS was also quite good, which is for us unexpected. We don't have this experience. But they also discussed that maybe for CNS disease with neurodegeneration, maybe you should start much earlier. The problem is you have an excellent, very impressive response. A patient with huge organs, transfusion dependent, fever, almost an intensive care. You start with the BRAF inhibitor, and after the second day, no fever. After a couple of days, after 1 week, transfusion independent. within 10 to 14 days complete clinical remission. But we started to measure the levels of the circulating cells bearing the mutation, and to usually see that they still have circulating tumor cells. And the problem is, once you stop the treatment, very quickly you have a lot of relapses. Almost all patients relapse. And this was more or less the same experience from the European group. We also published our data. It was not a study, it was a survey. Everybody who have treated patients collected the data together. Jean Donadieu from France collected them. We collected about 50 patients. I'm not sure that those numbers correspond to the publications because the study has been prepared before the publication came, but it plus minus one patient should be the same. What the paper says, we learned that we don't need the melanoma dose. It is very toxic. We give usually 20 milligram per kilo a day, divided into 2 doses, each 10 milligram per kilo, for at least 8 weeks. The patients have excellent response, 100%. Every patient gets into remission in our experience. The problem is that the remission is sustainable as far as you give the drug. But once you stop to give the drug, most of the patients will relapse. And the toxicity of this dosage is usually well tolerated. There is a limited skin reactions, but grade 1 to 2. So you can do the treatment in all patients, but you see what happens once you stop. The good news, once again, is if you restart the treatment, the patient will respond again. We haven't seen a second resistance until now. And this is one very recent study from the Sloan Kettering Memorial. They just decided not to say, is this BRAF or MEK mutation, just to give a MEK inhibitors. This means inhibitor downstream of the pathway. And they saw that all patients responded. And if you in the future have a ERK inhibitor, which is the bottom of the pathway, maybe it will also be effective if everybody. So this was a proof of principle that you don't have to care about the mutations if you give inhibit the pathway downstream. So to summarize the MAP inhibition, we have proven activity in patients with mutations. We have an excellent, very rapid response. We haven't observed secondary resistance so far, but we have to question whether the monotherapy can cure the patients. I know patients who give it now for 3 years, 4 years, and they're still in remission. But we think that it is not enough. You have to combine chemotherapy with inhibitors or 2 inhibitors. So we need well-designed prospective studies. In any case, we are happy that even if you're not able to cure, we can bring all patients into remission. We have at least superior bridging option. And in the past, we lose patients with this option. So this is what I can summarize. I'd like to thank to all countries who have contributed to the studies, to the Histiocitosis Association of America for supporting our centers almost 30 years, and to my colleagues in our hospital and my co-workers and these our institutions who supported. In early years, my boss, Professor Gardner, on the last 10 years, they supported me to carry the studies. So here's some literature. It's a little bit biased. There are some from me, but there are also from other colleagues, some very recent papers, which are excellent in blood by Carlos Rodriguez Galindos and Carl Allens from the States. So here are our guidelines. So you can read and you can look, maybe you find something better. Thank you for your attention. I'm open for questions.
Thank you very much for this excellent lecture, Dr. Milen. We have a lot of questions, so we could start.
Yeah, please.
So, well, first, they ask us, can you explain again what will you do for a patient with only skin involvement, especially with the granuloma, and how often will you evaluate him and decide to treat?
For patients who has a granuloma-like lesions, isolated circumscribed lesions, I would go for resections. But in my experience, such patients have only one or few lesions. They are like xanthogranulomas, and you can resect them and the patients are cured. And such lesions, even if you just wait and see, and you're sure it is a histocytosis, they have tendency for spontaneous remission. But if you have a rash, and it is widespread, my experience is that it is not self-limiting. It could, in few patients, progress, and I treat those patients like multi-system disease.
Okay, thank you very much. What do you think about the role of PET-CT in the diagnosis and follow-up of Langerhans histiocytosis?
Well, I'm an old man and quite conservative. I'm not a friend of PET-CT. To be honest, it has a role. There are some studies over the years. The problem is it is an excellent technique. It's very sensitive. You can theoretically use it to follow the disease, to follow the response. The problem I see is you have most of the kids very, very young. You need sedation. You have a radiation burden with both from the X-ray and from the PET, and therefore you can't afford to repeat it. It's also expensive. So I use it in my practice only for patients where I can't find another solution. For example, a patient is treated well, had bony disease, everything disappeared, but there is one lesion which is not healing completely. You still see it on MRI. MRI has one disadvantage that it is something like scars. You can see over years changes, and you can say are they active or not. And in such lesions which are for a longer time unchangeable, they are not worse, but they are not better, because if they get bigger, if they are painful, if there are some symptoms, I'm sure I have to treat them. But if I can't decide active or non-active for those patients, I do PET-CT in order to decide stop treatment, intensify treatment, or soil. But these are only few situations. I don't think that you have to use it in your everyday practice.
Okay, thank you very much.
Thank you, Doctor. We also have a very particular question here. They're asking, do you recommend the use of any medication to improve calcification due to the alterations in bone metabolism that these patients present after treatment?
We haven't done particular studies, but from some small series, from cases, we know that if you inhibit the osteoclast with other drugs like bisphosphonates, you can also cure the patients. There are many reports. There are case reports on few small series. I have also experienced it at least over this 15, 20 patients or more. And I can't say that those drugs can really cure everybody. This is the ultimate treatment, but I've seen a lot of patients with 2, 3, 4, 5 bone reactivations. You have repeated chemo, everything. The parents don't like it anymore and say, okay, the chemotherapy makes response every time, but the patient is not cured. Now we stop this and I give bisphosphonates, and most of them are cured. Of course, they can relapse again, but it is also good drug. So this shows that maybe supporting the bone metabolism could help, but in any case, the metabolism is not the problem. The problem is the active tumor or the active tumoral cells which activate the osteoclast. So you have to inhibit them, and we haven't done studies with, if you mean vitamin D, calcium, and so on. I'm not aware of this.
Thank you. We have another question.
Yeah.
A patient with eosinophilic granuloma and BRAF mutation, does it modify the risk of reactivation?
I don't think so. So I'm a little bit cautious to say about the BRAF and the prognostic significance, because the data are contradictory. They are good data from the French group, and I believe them. They have a very good catch of their national population, so it is not biased. But somehow there are at least three papers showing that BRAF is associated with more severe disease. But you can find a patient with singular bone lesion which is BRAF positive, and this contradicts the conclusion of the other study. So I think that what you have to do is not just to run everybody with 10, 15 patients and to publish a little paper. we start now within Europe, and I know in the United States, the colleagues also try to do it, to have the phenotype and the mutations in all the patients, and then to correlate it to the clinical outcomes in order to say this. I will not modify the treatment based on the BRAF mutation only, because you have not to forget that we have proven that it is somehow neoplasia, but like neuroblastoma, you have a phenotypes from self-healing till very progressive. This means if you have mutation in cells which are not able to reproduce them eternally, the tumor will succeed. So if you see such a child with singular lesion, I assume that the mutation is acquired in the cells which is not self-repopulating, and you don't have to change anything.
Thank you.
Thank you, doctor. Also, we have a question. Any particular suggestion for the assessment of the bone lesions in vertebra?
It's a very excellent question, a very difficult one, because if you rely on X-ray, we know how unreliable it is. What we tried in the LCH4 protocol is to give a little bit guidance what to do. So I tried that the important points after 6 weeks, after 12 weeks, that you don't make the decision based on the bone lesions only. Because the patient with a multi-system disease, I don't care about a new bone lesion. I care whether the liver is improving, whether the transfusion dependency is getting away. And therefore, it is a little bit difficult in patients with skeletal disease only, because you somehow have to say the patient sees the response or not. So you have, I tried in the past actually to do a score, but we never implemented it, because a score have to consider many things. You have to consider, do you have a clinical compliance? Is there a pain? Is there a soft tissue component, or is only osteolysis? And then you have to see whether the lesion is increasing or not. So if we decided to change treatment or intensify treatment only if at the point of evaluation you see new lesions, or you see that the known lesions are getting worse, bigger, or symptomatic, so on. In all other cases, if they are decreasing in size and so on, we say it is at least stable and regressing disease usually don't need change of treatment. So this is the way how to, otherwise you have to do PET-CT, but every 6 weeks on a child you can't do it, and you can't afford it, and it is a difficult, and you have to keep in mind those patients are not going to die.
Thank you. How frequently you see iron deficiency anemia in survivors, and is there any known explanation for this?
Well, I don't think that we have done such studies. Maybe you can have some data. Well, you can see a kind of microcytic anemia in patients with active disease. There are so many phenotypes. This multi-system disease has a lot of phenotypes. Some patients are behaving like a rheumatic disease. They have usually higher CRP. Those patients have increased platelet size, also like inflammatory parameter, and those patients can have some kind of microcytic mild anemia. Usually it's not transfusion dependent, but those patients have obviously systemic inflammation, and those patients usually tend to recur many times. If the patients are cured, I have not the impression that, maybe you have to look on this, I haven't looked at it, but I don't have the impression that they have a microcytic anemia.
Thank you.
Thank you. 2 more questions here. Which is the role of the intrathecal chemotherapy in LCH? And they also ask if, do you study the BRAF mutation in all of your patients?
Yeah, we do it in all of them, although it is difficult to justify. It depends on the healthcare system, because in most of the patients it doesn't matter. But at least in patient multi-system disease, you have to do it, because then you know that in case they are not improving, you can then consider it as a treatment option. But we do it also in the setting of studies, because we'd like to characterize our population and to find those correlations. So we do it mostly for the research purposes. But for the patients with the isolated disease, I don't think that you have to do it. If you can afford it, you can do it, because nowadays BRAF is easy. But you have to take care that about 1/3 of the patients, or up to 40%, will be negative.
We have another question.
Okay, the intrathecal therapy, we don't use intrathecal therapy in this disease, because the cases I show you with granulomatous disease, they can be treated well with chemotherapy, with 2-CDA, for example, can also radiate them. And the patients who have the neurodegeneration type, they don't have really active disease. So there is no role of intrathecal therapy in this disease. There is a role in HLH, but not in LCH.
Okay, thank you very much. I will have a final question. Considering our context that maybe we don't have access to many second-line treatment therapy for these patients, what do you think about etoposide and cytarabine with the relapse or refractory patient?
We did 2 studies which we directly assessed etoposide. The first one, LCH1 protocol to randomization vinblastine against etoposide, and there was a disappointment because etoposide didn't prove to be better than vinblastine. At that time, etoposide was the shooting star among the cytostatics. And then some years later, we also learned that it could cause leukemia if you give a total cumulative dose more than 8 or 9 grams per square meter, I think about this range. Then, nevertheless, I have to confess that if you read the publication very well, both drugs alone without steroids were not that effective, because most of the patients switched treatment before they finished the protocol. And in LCH2, we said, okay, maybe etoposide is better given in the combination. So it tried steroids with vinblastine plus minus etoposide. And once again, in the whole multi-system LCH cohort, there was no statistical significant difference. If you took only the patient with risk organ involvement, somehow was a little bit effect. But due to those 2 studies and those reasons and the risk for leukemia, we stopped to use etoposide, because it doesn't improve survival in the whole population. Of course, in individual case, you can use it. RRC has been published and studied extensively by the group from Ken McLean and Carl Allen in Houston. And they published that even as a monotherapy, it helps, but they have used it for non-risk disease. And in my experience, if you used RRC alone in really progressing patients with multi-system disease and organ dysfunction, it will not work. And the same is for the 2-CDA. It is also a good drug to treat low-risk relapses, but not alone. There's also publication by Sheila Weizmann that it doesn't salvage patients with severe disease. For those patients, you need 2-CDA RRC in combination. And 2-CDA has the disadvantage that you can't give more than 6 courses, because after the 6th course, the risk for myelodysplasia or for permanent aplasia is quite increasing. So you can do long treatment with clofarabine, but not with cladribine.
Okay, thank you very much. We have one last question. What is the role of radiotherapy in HCL?
We don't recommend it anymore. Maybe if you have some, I don't know, sometimes in different healthcare systems, you don't see some kinds of diseases because the patients may be diagnosed too early. If you see some patients with imminent or you're fearing compression of the spinal cord or something like this, there are some exceptions, but for the most of the patients, we don't use sedation because we have achieved the same effect with chemotherapy. In the past, it has been used for diabetes insipidus. We know that it doesn't revert diabetes insipidus, but the radiation can cause loss of other hormones of the anterior pituitary. So we don't recommend it in children anymore. Then we also have a risk for secondary malignancies, although the doses used in the 80s for LCH were not that high. They were up to 6 gray. But we don't recommend it anymore. I haven't used it for many, many years.
Okay, thank you very much. I think that that's all the questions we have. So
It was
on
pleasure.
behalf, again, on behalf of our aggregation and Dr. Marta Zapata, the president of our society, we thank you very much to join us today for this amazing lecture.
I hope it was helpful for you and it was a pleasure. Maybe someday I'll have time to visit your beautiful country, but I've only heard about it and we'll see.
Yeah, of course.
Keep in touch.
Thank you, Dr. Milen.
Bye.
Bye.
Thank you.
Si lo sabemos capitalizar de manera adecuada en ese sentido. Total y absolutamente de acuerdo con usted, doctor. Entonces, pues definitivamente estamos a sus órdenes.